So I'm going to kick this off with a few questions, but I would invite first the folks on the round table to introduce themselves. Well, I guess Lisa isn't here either. Oh, Lisa, come on up. And I'll ask you, is Jeff Holmstrom here? Jeff, come on up. Sorry, you're welcome. What?
I don't know if the light shines in.
Oh, is it right in your... Oh, we can turn that off, please. Can you guys turn off the screen?
I'm already follically challenged.
Sorry. But nice to meet you, by the way. Sorry, I didn't know you were here. Please have a seat. Good. All right. I'll just start here on my left and just go around to and ask them each to introduce themselves to CPAC and to the audience.
I'm Bill McQuaid. I'm a senior health policy analyst with the Rhode Island Medicaid program.
Hi, I'm Gail Hirsch in the Office of Community Health Workers at the Massachusetts Department of Public Health.
I'm Jeff Holmstrom. I'm the Anthem Medical Director, and I also practice family medicine in Saco.
Lisa Letourneau, I'm the Executive Director of Maine Quality Council, Regional Health Improvement Collaborative here in Maine.
Heidi Beckers, I'm a primary care doctor at Brigham and Women's Hospital in Boston and also director of the PAC Project, which employs community health workers in the University of Boston.
I'm Julia Wu, and I am an AmeriCorps Vista in the Office of Equity and Inclusion at the Oregon Health Authority.
Let's make sure, can you just move that mic a little bit more over towards Julie? So welcome, everybody. Julie came the farthest today. Again, usually...
I got in at 2 a.m. yesterday.
She kind of barely made it here. And we obviously are focusing on New England, but Julie represents the efforts ongoing in Oregon, where they have actually really hardwired community health workers into the transformation of their healthcare system. And I'd just like to invite you to briefly tell us how community health workers are playing out in Oregon and any reflections that you have about our conversation today and about what you think the lessons for New England might be for community health workers.
Yeah, great. So, well, to give you some background on myself, I joined the office 10 months ago for my AmeriCorps year. And the focus of my project is the non-traditional health workforce under which the community health workers lie in Oregon. So a lot of work had already been done when I joined the office, and community health workers had been recognized by my office as an essential workforce in promoting health equity. So that's how my office, the Office of Equity and Inclusion, got involved with looking at community health workers in Oregon and how to best integrate them into health systems transformation in Oregon. And it just so happens that at the same time as my office had a community health worker advisory committee, Oregon was also undergoing health reform and passed some major bills starting the coordinated care organizations, which are Oregon's form of ACOs. I think it was just perfect timing in that there were community activists out there pushing forth legislation and pushing forth the wording of community health workers, peer wellness specialists, and personal health navigators into that legislation. And that's how it kind of became in statute, and that's how we're able to move forward with integrating this workforce as we progress. So where we are now is we had a non-traditional health worker backtrack. So we have community health workers, peer wellness specialists, personal health navigators laid out in the legislation that developed the coordinated care organizations. And what that legislation says is that these workers must be made available to clients for culturally and linguistically appropriate care. And so a subcommittee was formed to look at the actual roles of these workers and what are the core competencies and trainings that they would need in order to succeed in their roles. And that initial subcommittee published a 90-page report that had their recommendations for how Oregon should move forward, and they identified the workers as a non-traditional health workforce, and that's how that name came about. Although right now there's talks to change that to traditional health workforce. So that name is up in the air. I think it will move forward into the traditional health workforce just to reflect the fact that these workers have been very much in the communities that they're in, but they're not recognized by the Western model of medicine. But anyway, so after that report was published, we looked at how to move forward with those recommendations and actually make them into policy. So I joined the office, and we brought together another non-traditional health worker steering committee, which is now meeting about once or twice a month to talk about the policies moving forward. And what we've developed now are administrative rules setting the training standards and certification guidelines for these workers so that they can be formally recognized by the health system, entered into a state registry, and that the coordinated care organizations can then hire workers from this registry with knowledge that they've met some sort of training standard by the state. So I think it's all moved very fast. I think all of this happened within 1 or 2 years. So I think right now a lot of the things that we're struggling with is trying to mesh the medical model with this more social model of approaching care. And I think both sides are struggling with that. On the community health worker side, it's very community-based and oriented really in the roots of the community. So it's hard to also take that and integrate it into the more medical model. And then on the medical side, I think what Heidi said before about needing to train the healthcare providers to know who these workers are, what they do, and how to utilize them is also going to be a challenge. So I think, let's see. I think that's kind of the major obstacle that we're facing, and then a lot of the little problems come out of that major overlap between the social side of medicine and the medical model.
Well, I'm a doctor and I have no idea what you're talking about. I can't imagine there's any conflict where we know what we're doing. So I'll ask you one question, then I definitely want to open it up to CPAC. So you're trying to do this all at once. There are going to be community health workers populating these community care organizations all over the state. Wouldn't it have been smarter to just kind of start slow and let first adopters kind of grow organically, and that way you can learn from the process? Don't you risk having the whole system come apart at the seams?
Well, right now what we are doing is giving a lot of local community control. So the state, aside from setting up the state training standards and the certification process, we are letting the coordinated care organizations do what they think is the best strategy for their community to integrate these workers. And I shared a few slides with Sarah Jane that show several examples of how different coordinated care organizations are going about this. So some of them are hiring non-traditional health workers directly themselves. A lot of them are looking to community-based organizations that have done this for a very long time and know the community. And so they're contracting with the community-based organizations, CBOs, to deploy those workers out to their client base. And then we also have models where the community health workers are integrated into the patient-centered primary care homes, and they serve as part of that team, serving the Medicaid population. And then, I think right now, a lot of the CCOs are in the pilot project phase of their community health worker program, so they aren't really going about it full force. They're taking it one step at a time, using community health workers for a small set of their population to see how well that model works, exploring the sustainable funding mechanisms, because right now it's also unclear like what the reporting mechanism is, and that's something that's still being developed with our Division of Medical Assistance programs. So I think we're moving fast, but also doing a lot of pilot projects and reevaluating and stepping back and seeing what can be fixed moving forward.
Good.
Is part of the moving fast because of the Medicaid waiver that Oregon got and the
Right.
need to do it all now?
Right. That's also part of it. So the waiver, community health workers were mentioned in the waiver, and there is an agreement that we will train and certify at least 300 non-traditional health workers, including community health workers, by 2015, and that these workers would be hired by the coordinated care organizations. And that's part of the agreement with CMS. So that's also part of it. But I think the coordinated care organizations do recognize the value of these workers, even though a lot more research and evaluation is needed for specific numbers. I think most of them recognize that this is a valuable component of their growing workforce, and a lot of them are exploring options of integrating them. And a few of them are at different levels, but I think they're all kind of looking to each other to see what works and what doesn't.
Okay. Now I'm going to try to moderate this conversation. It's going to be challenging because we all probably have questions, but and I don't want to focus them all on Julie and Oregon, but it'd probably take too long to have everybody give a statement. But I just point out again that we have people who've been community health workers and have led teams over many years. We have payers, both public and private, who may be involved in trying to figure out how payment structures for community health worker systems or patient-centered medical homes can work, and other kind of policy leaders. Gail's the leader of the Massachusetts Association, as she pointed out.
At the State Health Department.
Right, the State Health Department. So I have some questions that I think arose out of our conversations, but I would like to actually open it up to you all at first to ask some questions. Ellen?
Yeah, I mean, I obviously said high value, but I have a lot of concerns, and one of them is how do you make sure, how do you do the quality control? And you're doing training, and that's great, but how do you know whether the training you're doing is effective? I also hear from CHWs that, and from organizations, that supervision is a serious issue. How do you sort of deal with that, and how do you put standards in place so that payers feel confident paying for this?
Right. And Gail and I were actually talking about that because in Oregon, one of the obstacles that we've come across is that we can have training standards and set curriculum topics for training programs to go through, but we don't have a standard assessment tool for the workers. And that's something that I think is an important next step for more recognition for these workers. If they pass the standard assessment tool, then providers know that these are topics that they've covered and are proficient in. And then on the supervision piece, in Oregon, we have a specific agreement with CMS in our state plan amendment that lists the specific providers that can provide supervision. So they're licensed healthcare providers, I think was the terminology, and then RNs too can be delegated that role by the supervising physician. But I think that's something also that the CCOs are struggling with right now. And in the different models of deploying community health workers, the supervisors lie in different places. So there's one model that has a community health worker hub where there's a nonprofit deploying 10 community health workers to different organizations in their community. So they have contracts with the CCO, contracts with other organizations, but they have their supervisors centralized at that nonprofit. And then in the patient-centered primary care homes, the supervisor might then be in that clinic. So I think that's also something that the pilot programs are trying to work out, and there's different models for approaching it, and I think there might not be one right way of doing it, and it really depends on the community that those CHWs are targeting.
One comment I have to make about that is that I think we have to kind of expand our scope, because I would argue that in general, in healthcare, we don't do a good job of quality improvement or supervision. It's not just restricted to the CHW world. And I say that because when we've tried to integrate community health workers into either clinics or health delivery systems or into teams that are community-based, one of the things that we find is that there's a woeful lack of understanding to begin with of the population, what we're trying to do, what our primary outcomes are, or any mechanism thereby to know whether or not any intervention is having impact over time, whether it be at the data collection or analysis level, or just standard kind of continuous quality improvement. And I think that it's something that we have to figure out how to do in general with this opportunity we have now for healthcare reform in terms of really thinking about what we're measuring and how we're measuring it. I think the other thing that we found is that, and you know, as a primary care doctor, I say this with great love, within the medical world, we're horrible people managers. We haven't necessarily figured out how to manage workforces, even the traditional workforce, let alone a workforce that's out in the community contending with a lot of issues themselves. So there's a lot of learning that we have to do. And I think another thing, and I was talking about this with Rob when I was down in Hartford, is to do quality improvement, you need continual data stream, not only from the patients, but also from the healthcare delivery system and from the payers. And we haven't even figured out how to bring all those data together. So, you know, to put that on an intervention to say we're supposed to measure value over time when I can't access claims data or I can't access expenditure data if my patients are leaking to multiple systems, or it's impossible to get into electronic medical data and electronic medical record and get clinical outcomes data. It's really hard. So we've got a lot of work to do to really figure out how to do this intervention well, aside from just the CHW piece.
And I'd like to comment on that from, I'm a health policy analyst and an epidemiologist by trade. And even when we're looking at the studies that we reviewed today, I kind of frame it in terms of an induction time, a dose effect, and a duration of effect. So you start at some point in time and you say, let's introduce community health workers to this patient population. Well, they're not going to wave their magic wand on day one and have an effect that's going to be observable on day 30. There's going to be an induction time that needs to be taken into effect. And then also, what's the dose of effect that they're getting? Maybe in some of these studies, 2 contacts with a community health worker isn't enough and it didn't show an effect. It may also take more than 6 months, 8 months, 12 months, 18 months to actually start showing changes in their patterns of use, and those things too in the evaluation I think need to be considered.
You raise really important questions that we're grappling with in Massachusetts in a very intensive way. We're creating a certification process for community health workers and community health worker training programs. So this was at the response, in response to an articulated need from community health workers and from payers and from providers for exactly some kind of mechanism to answer those kinds of questions around quality. The tension that we're facing in the fine sort of balancing act that we're doing all along is how to support this profession and sort of professionalize it or support an emerging profession without erecting a lot of barriers to give this meaning, but to recognize the grassroots nature. So we're really actually just even yesterday dealing with those kinds of questions. How are we going to measure the quality of the training? What are we going to require of the training programs to actually demonstrate that they're actually being effective in training the community health workers so that we can present that information to the payers and to the providers? And as well, we're working with Oregon in some conversations to kind of think about what kind of documentation or assessment will we do of community health workers so that they're actually demonstrating competency. So we're really creating some kind of competency-based system that's flexible enough to meet these really, as Heidi pointed out, really sort of demanding and complex needs of the workforce and the populations that they work with.
So let me follow up with that, because this training issue, I think to try to understand how to move forward in New England, right now there are no credentialing or certification programs in any state. There are some processes underway. Does that mean that everyone should just wait until there is a formal certification? And I'd like to bring out some more conversation about this concern that if the genesis of the idea of community health workers was to draw people from the community, and often these are the most disadvantaged, poor access, poor connection, to professionalize those workers, don't you basically lose the whole point that you were about, because you wanted people who could connect with folks who hadn't gone to high school, who didn't speak English. You're going to require 40 hours of training and passing a test. Aren't we just creating social workers by another name? Mm-hmm. So I'm throwing lots of bombs over the wall at you. But part of it is, does everyone just have to wait until there is certification? And B, are we going to end up certifying people who aren't actually what we wanted in the first place?
I have to jump in. First of all, no one's waiting because people are doing the work. So, and we know that. So I think that the intent behind the Massachusetts law was to basically recognize and support the great work that's happening out there, and to be able to better articulate it and define it and role clarity and support and supervision. We also recommend training of supervisors as well. And your second question was beyond the do we wait, because I couldn't even wait till I jump into the...
It was to expand on this concern. If you're going to hire a community health worker,
right?
And you're a provider organization. and let's say you're not a community health organization where maybe a lot of your patient population could qualify for community health workers, do you want to focus them on a particular community and draw them from that community and not worry about training and certification, or do you want someone who's been professionalized?
Right, so I probably, probably the use of the word professionalized is very ambiguous. And I think what we're talking about is putting in place adequate training and support and supervision to actually make these workers to be the most effective that they can be. And we're definitely talking about looking at assessing competency not through an exam per se, but trying to be very creative, just like the workforce is, and actually figuring out some kind of interactive, participatory, real-life kind of way to actually assess that people have these competencies. So we're definitely thinking about those issues all the time as we move forward with this process, and I'm sure other people have. You look like you're.
Yeah, I mean, I think, I don't think we can afford to wait, but I think we have to continue to kind of do this. There's a lot of best practice out there around the country around training, not only upfront training, but ongoing training and supervision that are being collated and compiled that we can kind of learn from and draw from, as well as a lot of AHECs and checks out there that, you know, this is their living. They do training of CHWs, and those of us who are interested in a particular scope then augment that kind of base training to allow the CHWs to do the work we want them to do. I think around the professionalization issue, you know, the CHWs that come to us, even though I have CHWs who have never been employed or don't have high school education, I argue are already healthcare professionals sometimes in their demeanor and their ability to engage with people and really intervene. The onus is on us around making sure that a lot of times it's more helping them become legitimized and validated within a system. But what we have to do is make sure that they don't lose what allows them to be so incredibly effective, but also help educate the receiver end, which is the system or the payer, help educate them about what it is that they bring that they won't find in the traditional biomedical model. And so those of us who employ or support CHWs are educating CHWs in terms of things like being able to document, being able to email and text providers, being able to show up and talk about an MRI as well as the NSTAR bill, but also educating providers around what is it to provide more culturally competent contextual care. And the CHWs being able to communicate effectively with providers as they accompany patients is also part of their professionalism training. And I would argue that most CHWs have an innate capacity to learn. They're incredibly able to kind of soak this up and give more. So I'm not at all concerned about losing their essence.
And a lot of what I have to say actually echoes what Gail and Heidi said. So what Gail said, a lot of this is already going on. So there are already community health workers out there. But what the certification does at the state level is give official recognition to this workforce and give them a place in health systems, well, in Oregon, give them a place in health systems transformation. And as we were developing the rules in Oregon, what we really wanted to make sure was that we were not imposing additional barriers on the workers themselves from getting into the system. So we formed a 15-member steering committee that's composed of the workers themselves, training programs, community colleges, CCOs, hospital systems, and other stakeholders to inform the process for us. And throughout the process, we really recognized the importance of lowering barriers for the workers and making sure that training is accessible in their communities. So some of the things that we've written into rules, having no fees for certification for the workers, ensuring that the training programs are delivering training in a way where they recognize the community that they're serving. So if it's in a rural area and people don't have access to easy transportation into a central hub, maybe having that training be every single day rather than spread out over months. We also want to make sure that the training programs that are training the workers are using methodology that the workers use themselves, like popular education methods or adult learning principles. And we want the training programs to involve the community by collaborating with community-based organizations, and then involving the non-traditional health workers themselves in teaching and developing that curriculum. So as we were developing the rules, we really did recognize that tension between institutionalizing this workforce, but also maintaining the integrity of that community and peer-based model. And it's kind of hard to balance because we are writing rules around a community workforce. But I think we hopefully were able to find a reasonable balance to ensure that we're still recruiting students into the training programs who are from the community and have the qualities that you really can't train into someone, the shared life experience or knowledge of the place that they're living in.
Jane,
So can I borrow a mic?
why don't you use that one?
Please. So first of all, Julie is a testament to the AmeriCorps program and the worth and value of the AmeriCorps program. So congratulations on your year of service. And I want to know who's trying to recruit her because y'all ought to be on it.
Next year.
But my question is actually aimed at the middle of the table a little bit and our pair, not that middle. So most of a lot of systems in our states are transforming towards more accountable care. We all are going to be, well, as providers, we're going to be accountable for the care of whole populations and whole communities. How do you, I mean, I can see how this should all work, but I'm wondering how you see it's going to get paid for. And that's what this whole meeting's about, isn't it?
I'll jump in, I'll ask Jeff, no.
Now
Well,
she's
you know,
gonna tell me how.
Yeah, I'm going to tell him.
I should never let her go first.
She's just going to tell you to pay for it.
No, no, no. We're already past that stage in our relationship.
Yeah, we are. In fact, you know, I was joking with somebody at the beginning of the day that when I talk a lot about primary care and needing to build a stronger primary care system, I think this is clearly potentially part of a primary care team as well as the rest of a larger redesigned model. And now when I talk to health systems, and they're largely, with all due respect to my colleague where I am, you know, hospital-based health systems, I like to sort of throw the challenge out and use the old pogo slide. We have met the enemy and they are us. I mean, we have got to decide. Jeff, the good news is I'm not going to turn to you and say that because I don't think anybody would kid ourselves to think we're going to convince payers to pay for new services these days. I mean, maybe, but I think it's highly unlikely. I think the real expectation is that this is going to be built into a redesigned delivery and payment model. But I think when we start from, again, with all due respect to my colleagues, hospital-based systems, this is not often the way they think, nor, to their defense, are the current redesigned payment models of a particularly shared savings models, which is largely what's out there, particularly conducive to investing in this kind of thing, right? Because they are still getting paid on a fee-for-service basis, and their services are going down because they're doing the work they're supposed to be doing. So, you know, we joke often about this foot in two canoe things, and one of those canoes is sinking, which is the revenue that they're getting. So I think I'm really intrigued with a model that I heard Oregon do, which is to set it as an expectation, you know, so that, and at the same time, I think we have to feel confident enough, encourage our provider colleagues to feel confident enough to take a wider, more global payment kind of model than just a shared savings on a fee-for-service, because it's still broken fee-for-service. And until they have the ability to break the chains of fee-for-service, they're just not going to have the extra revenue, the latitude to invest in these kinds of systems. So I think the combination of courage on all parties, and I don't quite know how to get to that, you know, some magic pill, to really move to truly different payment models, as well as an embedded, ingrained, maybe regulated expectation that these kinds of models be included. I mean, I think if I heard you right, Julie, you were saying that it's simply a part of the contracting between the state and their, I would say, around collaborative care or Coordinated care, sorry,
Lots of
organizations,
acronyms.
that they must include that as part of their model. So I'm thinking, we have a Medicaid program that's about to come out sometime with our accountable communities contracts or RFP. Boy, there's an opportunity right there to build it right in as an expectation, because I can almost guarantee you that our cash-strapped, revenue, poor, hospital-based health systems right now, some might argue about the revenue poor part, but, considering that they're trying to maintain the systems that they have, are not going to have the whatever to invest in things like this unless they are both required to and/or truly have different payment systems to do that. So, see, I got you off the hook. Yeah.
And then in the Rhode Island Medicaid program, I'm sorry. No.
I'll get back to you. Go ahead. No, you go ahead. I'll circle back to you.
Okay, but in the Rhode Island Medicaid program, okay, we've got a communities of care program that's kind of an emergency department diversion program that has a component of community health workers in it. And we've got a price tag on it. I mean, it's funded by a CMS grant, and it's that the health plans get 32 cents PM to implement this program. So that's kind of maybe a nice round number for how much it costs. But it's for everybody, not just for the people that are in the program. But the idea is that hopefully we're going to find savings from this that we can find somewhere else in the system. And then we do have capitated arrangements with health plans, and care management is a portion of what we pay capitation to provide. So we pay them a particular capitation rate for medical services and administrative costs, and part of the administrative costs is the care management. And so I think we have some wiggle room there in terms of when we come up with our capitation rate, what we put into care management and how much weight it gets in the ultimate capitation rate. But hopefully there'll be savings that if this works, there'll be savings.
But you need some upfront revenue to support the services, to create the savings.
Let's talk further about this, obviously. I think it is an important outcome of this meeting, is to try to provide some insights into ways to do the structuring of it and to pay for it. So help me out. So I'm a provider organization that doesn't currently use CHWs, but you tell me you're giving me a management fee as part of your capitation. Are you trying to tell me that I should now hire brand new staff and figure out they're a full-time staff and figure out how to deploy them as CHWs from scratch and pay for it from what you're currently giving me as part of the capitation fee? Or are there other, I'm trying to figure out how people get from zero to there, because we're talking about people, we're talking about infrastructure, and I mean, I suppose you could hire, I mean, that's the thing, there are no agencies out there where you can kind of dip your toe in the water and have one for a little bit and then pass them on. So I'm trying, how can we work with the startup and the payment structure dynamic for provider organizations? Thoughts on that? And maybe at this point we'll bring in your thoughts too if you have any.
Well,
Go ahead.
Why don't you go
Whichever
ahead?
one's going.
Because
You go ahead
Yeah,
first, yeah.
No, but just actually, what I'm learning is that I'm getting into more rate management meetings than I've ever been in the past. So I'm finding out a little bit about how the sausage is made. So in this case, what we're hoping is that we got this grant, and we're going to give them we're going to give them a boost to get this thing off the ground. The idea is it maybe shows some benefit and some cost benefit that we can somehow find a way to fund in the future. And yeah, we do, what they do is, what the health plans are doing now is they're outsourcing the community health workers. They're going from another organization, they're contracting on a temporary basis with other organizations. But if we can figure out a way to pay for it, they'll figure out a way to keep them on board. And if we can demonstrate savings, it's going to be easier for us to do it. There's also funds too from the primary care medical home initiatives to start doing that stuff in. So, you know, eventually, I mean, I know it sounds like the old slippery slope, but I would imagine 10 years from now, we'll have figured out a way to pay for the things that we want to pay for.
So is what I'm hearing that a lot of places, and this is my understanding, a lot of places are relying on grants to kind of get things started, and without grants, people are saying, are you kidding?
Yeah, I mean, it depends. I think that for the that's been a huge issue with CHWs, and I think one of the reasons why so much of your data were disease-focused was that we had to do what the whim of the grant maker was. We want you to focus on diabetes, we want you to focus on asthma. But I have noticed increasingly kind of these alternative quality contracts or global payments that are being made out to safety net institutions or places that are getting health home CMI dollars, that they are getting either through their administrative costs or their care management costs. They're really looking at, well, what can we afford? And one of the arguments that we're trying to make in the CHW advocacy world is, well, instead of buying, 6 nurse care managers, buy 2 nurse case managers and, 30 CHWs, because the incremental value that you're going to get, depending on your scope of work and what you're targeting, is so much greater. And so our opportunity to really go in and talk to these healthcare, either delivery systems or health homes, about how they can reconfigure their interventionist team is really useful, using that sum of money. One of the things that have come up in Massachusetts, which I think is unfortunate, is, and people have been probably watching this, but the integrated care organizations. So initially there were 6 that had signed up, these payers that are going to create essentially health homes for dual eligible patients who are very costly. But one of the things that happened was they only gave 99 cents per member per month for the care management fee. And a lot of places are saying that's just not enough to pay for anything, let alone a CHW. So we still have a lot of work to do to figure out, what are we investing in? If we're investing in wellness and prevention and community-based care, we have to make more of an investment on the dollar. And as you mentioned, we're still in the fee-for-service, biomedical, hospital-based world. We're spending 3% of the dollar on medical spend in primary care. The argument is, if we could just get up to 11 to 12 cents of that dollar, we could probably cover these costs. But as a system, we're just not there yet.
Jeff, what I know there are lots of other
Well,
things, but from your perspective, again, from a
If-
private payer, where does the world of CHWs intersect with what keeps you up at night?
Well, I'd like to step back and just give a shout out to my community health worker friends. I was very impressed with your passion, and had the luxury to train medical students throughout my career. And some of the things, when you're talking about checks and what makes good training and what doesn't, are the intangibles. And to me, things that are necessary for whatever level of healthcare delivery that you're going to be in are intuition, compassion, and altruism. And those 3 things are essential at any level: primary care, community health workers. And if you could create a score that rated those 3 things, I don't think you'd have to go any further. Okay. And those are things that draw people to want to help other people. And I've seen that. And when I go to, I can remember being a resident and having residents underneath me, and they'd want me to sign off on their logs. Remember logs? I did this many lumbar punctures, I did this many that, and this. And so there was never a checkoff for those 3 things that I mentioned. So I'll step away from that, but I think when a group is considering what are the key components of a community health worker, those 3 things stand out first and foremost. That said, I think from the insurer's point of view, we have business on different levels, and let me give you a little insight into that and where I think we're going. Anthem has national accounts, the Verizons, the Krogers, the big businesses, and they're getting more and more concerned about the cost. They are very concerned. But what they want us as an insurer to say is, we'll do this for your member at this price. And to a certain degree, they don't get that low to the ground, that granular. Is it going to be a community health worker or whatever? They just want to make sure that the outcomes are good, that there's a return on their investment. In the local market, where we are in Maine, and I feel so blessed to be a medical director for Anthem most of the time in Maine. But the reality of it is that we have a very collaborative state that's very forward-thinking, has been early adopters of meaningful things in healthcare delivery. And when you couple that with grants, my partners in quality counsel and such can coerce, push, or nibble at the edges so that I can get some money to play in a pilot. Okay? Well, coerce, I'm being a little harsh. But so where I'm going with this, and I want to sum it up, is that we can't wait. We're not going to wait. I think a community health worker is an essential part of this. For us to wait to define what their roles, responsibilities, and training are would set us back too far. We're going to put trust in the fact that local pilots grants are meaningful, and we'll study the outcomes as we go forward. I think that we're taking a leap of faith. When I talk to hospital systems, they don't want to step off a cliff, but they don't mind putting their toe in the water and incrementally walking down to global payments and total risk. So it's courage, it's a leap of faith, and it's incremental change, but fast track primary care has to be at the forefront of this. And I think that the community health worker is the bedrock. I got to tell you, when I first started doing managed care in a small company that was called Nile Care, we used to call it denial care, vile care, no care. The first person I hired was, after a utilization management person, was a social worker. And that was in 1997, and it was a great experience. And in my practice right now, I have a social worker that sits across my hall, and I go in and out. So there's that kind of thought process that I think resonates with me, and I think that what we do in the local market here will lead to where we see healthcare and insurers at a national level go.
So let me follow up with that, if you don't mind. I know I'm hogging the floor here, but so we heard about the two-canoe problem, where there's some alternative quality contract type global capitated arrangements. There's still some fee-for-service. And she was hoping that there would be an expectation hardwired in that part of the contract will be that you, provider group, use CHWs, and maybe you even stipulate how. As a payer, when you're designing your contracts, where are you now and where do you think you want to be with that kind of stipulation? Because I'm not hearing that in the private insurance market right now.
Yeah, I don't think, one, we have enough experience with it, and two, we don't want to be prescriptive. We have a program called Patient-Centered Primary Care, which is essentially a patient-centered medical home approach for Anthem, and rolling it out and spending a lot of money. And I was on the group that started to write the provider manual, which is a really scary thing. And after about 6 weeks, we realized we were too prescriptive. There were certain elements that had to be there, and things that you had to check off. And then the rest of it is you got to leave to the subject matter expert in the office and the local market, and then give them tools to help improve their delivery system and monitor what they're doing and find out what works. Lisa's got a great job of learning collaboratives with the Medical Home Pilot here, and we're trying to copy that so that everyone that's got one of these pilots across the country can share best practices. So payers, I don't believe, are going to get that prescriptive to that level, saying you must hire 20 community health workers, they must have these qualifications. It's going to be, here's some money, you guys are experts in your community, you know what resources are already there, so to your point, you won't have to hire a fresh body. You can leverage someone that's doing some sort of care in that area or that arena.
That's a whole other conversation I'd love to have, which is we've got a nurse or a nurse's assistant. Can't we just use them
Right.
as a community health worker,
Yeah.
right? We don't want to buy a new body. I want to actually, Rob, I was going to ask you anyway at some point, but why don't you go ahead and jump in?
First of all, my day job is finding me quite a bit right now. We're looking at doing something like this in Connecticut in a Medicaid, possibly a broader arena. And we're currently a lot of small practices and almost entirely fee-for-service. And when you raise the idea of working with community health workers, with physicians in the private sector, their response is almost immediately, well, what's it going to do to my liability insurance? Connecticut we do have the second highest liability claims settlement levels in the country, so it's a big issue there. But I suspect it's probably not an insignificant issue elsewhere. Has this come up? How have people addressed it? Is it a barrier? How much of a barrier? Please fix it.
I can tell you, we probably haven't gotten to that level of thought with respect to a community health worker. And Lisa, you've got community care teams, and the pilot has that. I was not able to attend your work groups to that level. Has that come up? I know there was discussion with the physicians about it, but.
It really hasn't, but we have a somewhat different model in Maine of community care teams where it is more licensed folks, so it tends to be more nurses and social workers. We encourage the teams to be creative and use other resources like community health workers or coaches, but it really has not been so much of an issue. But I'd be curious in the states where you are using it more,
Well, I can't speak, I guess, to the specific physician concerns, but I can speak to the state concern of liability, because we are setting up a certification process and saying you're state certified as a worker. But then what happens if you go out, get employed, and then do something wrong in someone's home? Is the state then liable, or is the employer liable, or is it the direct supervisor? And that's something that I think, as the state, we're still trying to figure out. And one of the major hot topics right now in Oregon is the criminal background check for the certification process. So we've had this discussion for the past few months about whether the state should incorporate a criminal background check into our certification process to decrease the liability for the state, or whether we can write a disclaimer onto our registry saying that it's up to the employer to do this. And at this point, we do have that criminal background check, but that's one of the topics within that bigger liability conversation, I guess, about who ultimately is responsible for what that community health worker does in someone's home. And they might be going to that person's home by themselves, so who's the direct supervisor and how much supervision is there on the ground? So I'm not sure if that answers.
Physician.
Yeah, so I think that, so it depends on who the employer of the CHW is, and then also who, the accountability of the CHW, who does it track back to? And a lot of times, a lot of the physician, in my experience, the nurses who get anxious about CHW, it's just helping assuage some of their fears that it doesn't get tracked back to them, that this is about team-based care of a patient, and that the CHWs are trained to follow protocol, and it's up to the supervisor to ensure that they don't extend beyond their purview, and putting those systems into place to kind of allay some of their fears. I think the other thing is, in our experience, and we actually studied this, there's really never been a lawsuit against a CHW. And so to kind of help people understand that it's a theoretical risk and it's something you have to think about and, put guidelines into place, but that it's probably more of a theoretical fear than not. The other thing I often share with my physician colleagues or nurse colleagues who get anxious is CHW's job is to accompany the patient in terms of learning self-care or modifying behaviors, doing motivational interviewing, adherence, whatever. We basically say that the community health workers have limitations. They can't put pills in mouths, they can't inject, they can't do certain things that they're licensed to do. But when there's anxiety about, well, what if the community health worker checks a blood pressure and they report that blood pressure incorrectly to me, and then I increase the atenolol and the person gorks out and comes into the hospital with an aspiration pneumonia. What we often say is, well, the CHW's role was to help the patient check his or her own blood pressure and report that in. There's no, that doesn't necessarily get tracked back to the CHW. And so I think it's something that we have to figure out how to create guidelines around, but I think if you actually start going through scenarios, it helps allay some of the anxieties.
I saw you had a question. I'm actually going to stand up so I can make sure that I can see the other side of the room better. And what I thought we'd do is have this kind of conversation for about another 10, 15 minutes, and then we'll probably shift towards looking at the specific best practice recommendations that we have in black and white and start to discuss as a group whether we need to amend them or expand them or what have you. But let's keep going with this.
Just address my question.
Oh, she did? Oh, okay. Well, Rob, did that help? I mean, I was interested to hear that concern being raised, and did those answers help?
Yeah, they do help. I think that at least for us, and especially in our private community, it's so new that I don't think any argument is going to make it easy.
Oh, sorry, can you speak in the microphone? I don't think other folks can hear you.
I think it is helpful. I think the difficulty is that it's so new with where we are and where we're going that there's going to be a lot of the fear factors to be overcome, and we'll just have to whittle away at it.
So I'd like to structure, oh, go ahead. Rob, go ahead. Oh, I'd like to structure perhaps a couple of questions, well, one question. Getting back to this idea of dipping the toe in the water. So Oregon is taking the big cannonball off the deep end, without a doubt. I'd like to be able to put into black and white some approaches to dipping the toe in the water for provider groups, for payers, or others, and try to, again, kind of create, because I heard somebody mentioned that they could contract with, a CHW organization to dip their toe in the water. Can we get a few specifics around that and around how those structures have worked, those contracts have worked, and whether, for instance, they're targeted on one specific disease or whether they're hired to do a variety of different activities? Heidi or others, when I try to help people who want to dip their toe in the water, perhaps, what would that look like?
Yeah, I think it depends on, where you go. And again, because this is unfortunately a relatively nascent field in terms of the ready integration of CHWs, there's some states that are replete. You go to Texas, for instance, or California in some areas where, you throw a nickel and you'll hit a CHW, whereas there's some places where, they're just not around. I think that some organizations feel like they want to contract out and will identify a community-based organization that is willing to basically either adapt their existing health force, or their existing workforce, let's say they're care managers, and create them into CHWs to address the needs of the client healthcare delivery system. So I'm thinking about a group, for instance, in Albany, New York. It's a Medicaid managed care company that what they were trying to do was they were trying to reduce cost in their top 15% of their utilizers that were accounting for 60% of their costs in Albany. And what they first decided to do was to hire 3 CHWs as payer employees to basically go out, track these people down, and do some sort of intervention with them to prevent them from going into the hospital, going into the emergency room. And after 1 year, they discovered it was a mitigated failure. And when they did kind of a post-mortem analysis, figured out that the community health workers, because they were viewed as payer employees, were not legitimized either by the healthcare providers or necessarily by the patients. They weren't integrated into the system enough. So what they then decided to do was to contact one of the community-based organizations that has a big footprint that does mostly prevention work and violence prevention work in Albany, and said, we're interested in this CHW who's going to focus on our high utilizer, high cost people. Would you consider hiring some of these people or transforming your current care managers who are doing violent prevention work into community health workers? They said, sure, if you can pay us, absolutely. So they contracted with the CBO basically to do this work, and then the CBO is then trying to figure out how to train the CHWs to do the work allied, and so they've created this nice little, triangle between the payer, the healthcare delivery system, and the CBO. There are other places that they can go and actually go into a community health worker organization, or they can contact MASHWA or something and say, we need ready CHWs who have had.
So let me
certain
break in
kind
there.
of
So in
training.
New England, is the first number you call the state association, if there is one, to try, is that the dipping the toe in the water, or do you go to a local organization, and if so, which one to get started?
I mean,
It may
Massachusetts.
differ by different states.
Yeah, I
but-
mean, and it depends on the region in the state.
Yep.
I'd
Well-
start with the primary care medical homes.
Well, they don't,
Well-
they don't employ community health workers, at least in Maine. I mean, it's a new model to them. Some of them have patient navigators, but they're not contracting them out to other organizations. And I would think the same thing in New Hampshire. I don't think there's anything going on. There is no Maine Association of Community Health Workers, as far as I know. So.
New Hampshire has some, particularly FQHCs that have
Yes.
some community health workers,
Patient
but
navigators.
it's not, there's not 1-800. So
Yeah.
Right.
In
Yeah.
Massachusetts, as we have 3 robust training centers that can be contacted for graduates and for connections to the graduates of the training program.
They come out of community colleges, or?
No, they come out of community-based community health worker training programs located in 3 regions of the state.
That are freestanding or part of?
One is at the Boston Public Health Commission, one is at Central Mass AHEC, and one is at Lowell Community Health Center.
So then let's take a state without an association where you could call at
We
least,
could call
and
the
get some
association
guidance.
as well, yeah.
But for the states where there's no association, again, what's the guidance for them? Is there a typical local organization that they would, if they're looking to hire or to even get advice on what to do in their region? I mean, we hope to produce a report that will help people in general, but we're going to need to guide them in some way for how to take that first step in wherever they are. So I'm kind of specific. Si, did you have
In
something?
Vermont, I think what Heidi said about existing organizations like the AHECs, there are 3 of them, but I know the one in the Champlain Valley specifically is kind of the state leader on language issues, particularly because we have a lot of migrant workers and political refugees up around Burlington, south of Montreal. So even though they're coming out of the AHEC, I think that they're a little more focused than a community health worker, but they certainly could build a base. And then like the AAA's area agencies on aging have similar people, but they don't have, none of them are referred to as community health workers.
This is obviously tricky because, as you know, people who want to do this function, if they can't find a 1-800 community health worker, they're going to find a 1-800 nurse case manager or visiting nurse or some other kind of model to try to graft into that function, I would think. Is that what you're seeing in the policy and practice landscape?
Yeah, or make it up, sort of develop it
In-house.
themselves, right,
Make
right,
it up.
without the real community orientation. Yeah.
If I were gonna make a recommendation in a report, I would suggest pushing out to the AHECs
AHECs is probably the
in
most
the whole
natural
region
place,
that this
yeah.
is an issue. Many of them are trying to respond to it anyway. And,
AHECs and community colleges maybe.
yeah,
would be the other.
and community colleges.
Can I ask, how does Oregon, you have your training systems, how did you deal with this? You've got to get a whole new workforce up and going.
Well, so I think I agree with what a lot of people here said, is the infrastructure was already there at the community level. So there were a lot of community-based organizations that had community health workers of their own. A lot of FQHCs had community outreach workers, or they all kind of went by different names, but they were serving similar roles and serving as that liaison between.
So you were already way ahead of us, you didn't have
So
this
I think
problem.
there was. I think community health workers were there, and I think most of them were funded by short-term grants, and that was where the recognition came from the state that there needs to be a more sustainable model of financing these workers, because as the grants change, their roles change, or their jobs get lost, and they have to become volunteers. And I think that's where also that push to get Medicaid to fund these workers also came in, to make it a more sustainable workforce. So I think it starts off at that community level, and then a lot of the CCOs, rather than jumping in, they are looking at the community-based organizations in their area, doing contracts with them to serve that population. And then some of them, I think, are looking forward and seeing if they can bring in community health workers to hire on directly. But I think they first have to build their own internal awareness of what this workforce is, and that comes from the community itself.
So let me ask another question. In today's realities, we've talked about it today, where there are no new resources. I mean, there are grants that have often been used to get these things started. But if we're going to advise people about dipping their toe in the water, and based on the evidence, where at least in many disease management areas, the only areas that have been shown to be cost neutral tend to try to identify the highest risk within the highest risk within the highest risk. And only if you target those patients will you be cost neutral or cost savings. Is that the approach that community health workers?
Right, in the short term.
I gotcha, admittedly. If that's the evidence base from which people are partly operating in their heads, and people are interested in dipping their toe in the water, is that a way that community health workers should be targeted, or is that a mistake? Should we try to design systems that will go after high utilizing disadvantaged patients and try to focus community health workers there? Is that a good way or a bad way to start?
Well, Lisa, I'm not sure if I would say it's a good or bad way, but it is absolutely the way that we have started here in Maine as part of our multi-payer patient-centered medical home pilot for exactly that reason. I mean, we are part of a 3-year Medicare demonstration, and now it's become a 5-year multi-payer demonstration. And we knew that we had to show something in that timeline. So we had many discussions about this as a community, while we're all for addressing issues with, wider community concerns, or, have interest come up from an organic nature, we knew that in order to have any hope of showing a return on investment in even a modest modestly expensive new model of care that we had to do that. So that is what we've done through our medical home pilot, and it's actually why we call it a community care team and not a community health team, because we say it's really about focusing on the most high-cost, high-use, super-utilizing patients, much like the Camden Coalition and Vermont folks and North Carolina folks have done. And we haven't formally sort of called it community health workers, but we encourage teams to evolve that include nurses, social workers, and community-based workers like community health workers and patient navigators and health coaches. So
Yeah, I would have to say that we don't want to make providers schizophrenic, and if the feds are focusing on that, and Lisa's pilot focused on readmissions, ER reductions, and ambulatory sensitive care admissions, that's where the payers are going, because you don't want to create two different delivery systems in a primary care office. I handle this group this way and this group that way. So if they all can focus on similar targets in the short term, it allows them to justify the transition and make it more effective in the office.
Comment.
Sure, Mitchell.
Lisa and I have had this conversation before. I completely understand all that reasoning for the short term, but I worry about setting up the right systems for the long term and the focus on population health, which everyone acknowledges we need to go to. I'm not seeing the way forward if that's the initial step, because it does seem to reinforce the existing system and just finding a way to work around the edges of this system instead of creating the new one. So if the panel can comment.
So I totally agree with you, but I would challenge, how are we really defining population health, right? So for those who are measuring it right now, or say they're measuring it, it's CMS, and their population health measures are clinical care measures on the insured population. There's not a single ACO that I know of, at least right now in this country, that includes true population health measures, which means either true population, geographic population, or true health, right? It's chronic disease measures in the defined insured population. So again, I don't blame the provider organizations who are narrowly focused on this, and the payers who want to see the short-term return, but we've got to make policy change to really measure what we say we're talking about, because we are not right now.
How do we get there?
Yeah, policy change. I mean, we have a Medicaid ACO about to start in this state.
I've heard that.
Yeah. So what are those population measures going to be? Are there going to be any true population of a region, not just those covered lives? And are they going to really include any true population health measures, not just healthcare outcomes? So,
Yeah, I mean, I concur that to get, one of the things that we found, in talking to the Camden coalitions and stuff, is you focus on that crust, that 3%, their baseline costs are just so ridiculously high that whatever you do, however expensive it is, you're probably going to get a short-term ROI. But stepping back, what happens often is that 3% changes the next year. The churn is so high, you're not dealing with the same population. So you're a short-term ROI, but they're not the same people next year. And we haven't just figured that out. I think, taking a long-term view, I mean, this sounds socialist, but eventually what I would like to see happen is that CHWs really are the base of care, and that people are referred up into more licensed, professionalized care as needed. In addition to kind of making the financial and the logistic argument, there's a shift that we have to do as a people and as a biomedical system that has benefited with the alternative, and I think we have to start somewhere. And I do think, though, that there's a role for doing more careful, true kind of health home pilots that are addressing the needs of the population as a whole, where you can see that there are CHWs who are focused on the 3%, and there are CHWs who are focused on the 4 to 20%, and there are CHWs who are focused on the 21 to 100%, and you create systems where you're able to ratchet up and ratchet down, utilizing the system. I haven't seen a whole lot of people doing that kind of work, but my hope is that that's exactly the kind of thing that CMMI is going to fund in the future, that kind of approach, as opposed to complex care management to get a quick fix now to demonstrate the efficacy of a particular person.
Yeah, and in Rhode Island, there's a couple of initiatives going on like that. One is the primary care medical homes are becoming, there's going to be 21 more joining as of July 1st, and there's a very concerted effort to get more and more practices involved in that. Also with the exchange and the all-payer claims data systems with the Affordable Care Act, there's going to be more effort to start measuring population health. We're going to have data on everybody, or most people. Yeah. Well, and as the insured become more and more, I mean, 95%, 93% is better than 82%. So, you know, I mean, we're getting there, and there are some concerted efforts to do it.
All right, I'm going to ask each of the panelists if you had to, based on the evidence, and I know that's always a hard preamble to most, based on the evidence, if you had to make a claim about the strongest evidence to support a specific community health worker approach, and that would include what should the target condition be, what should the structure be, how should it be? I mean, I don't want to give you too long to describe this, but based on the evidence, I'm trying to say, what would you say is the surest bet if you were trying to make a sale to an ACO? You're not going to lose money on this. You're going to make money and make people better. And based on the evidence, here's exactly what you should do, and nothing else. All right, so we all know what we'd like, perhaps, or what would be best. But based on the evidence, I can convince a room full of hard-headed business types, here's the evidence that you're going to be okay if you do exactly this. I bet my life on it.
Can I bet Jeff's life on it?
You often do.
I'd go at it the other way. I mean,
All right, good. Somebody was willing to start, so we'll start at this
I
end.
go at it the other way. I'd say take a look at your case management, and take a look at your diabetes case management, and see where the gaps are. See who's not responding to the treatment that you're providing them. And then if you're not satisfied with that, then ask, what else could you do? And if what you're doing isn't working, try something else.
Well, that doesn't sound hard-headed enough. You've got evidence that you can take my gaps. There are always going to be gaps. They're the ones you can never reach. What's the evidence that I'm going to reach them and make a profit?
I'm speaking from someone who's been involved with a system that's been making a killing in the fee-for-service model, and decided that the population that they were most concerned about in terms of their losses were the elderly, Medicare, as well as the duals and the disabled. And I think it's right, and you talk to Medicaid, and certainly because a lot of people have to spend down to basically then get Medicaid to pay for their 20 years in the nursing home, and our population is aging. We've got to figure out this long-term care for the elderly and the disabled. And I think if we take a broad societal view, I think any kind of intervention that's community-based, that's going to keep people healthier at home, out of institutions, is going to make sense. That's where I would apply the CHW. And as we know, for a lot of that, the intervention is relatively minimal. And I think in the end, it would be a huge savings, and we're savings and benefit. But we haven't really done any large-scale demos of that, and that's where I would go.
To get evidence, not to say we've got evidence that will work.
Yeah, I mean, I would, yeah. I mean, I think there are some evidence out there that are highly suggestive that this would work.
Would it just be the elderly, or would it be specifically the dually?
Duals.
It would be the dually eligible?
Yes.
And the...
And that includes SPMI, physically disabled.
So not just the elderly duals, but both duals?
Correct.
Right.
I think it was an unfair question.
Thank you.
Because nobody 10, 15, 20 years ago ever asked an insurer or Medicaid, give me the business sense for your case management programs and your utilization management programs, that they are going to make any financial difference.
Mm-hmm.
Thank you, that's true.
And if
Well-
we got 1%, we were happy.
Well, I was part of conversations where those people were rung over the ringer over their evidence that utilization management would work. I'm not saying that a lot of things didn't happen without evidence, but in today's world, I think I'm just trying to get some helpful feedback, because I think in some rooms that will be asked, because we've kind of skirted over the obvious, which is it's hard to study these kinds of interventions and a workforce as a whole. And so it's easy to shoot at it because there's not a lot of evidence. So if we're looking for the strongest evidence to support a better improvement in health and cost neutrality or cost savings, what's the bedrock on which CHWs can sit today, recognizing that there may be more to come?
So I'll just chime in to say I pretty much agree with this approach, although I thought the question maybe was unfair because you didn't say in what time frame and with what payment model, which are clearly, so, you know, if we use the real world, which is relatively short time frame, and current payment model that most provider systems in this state at least are operating under, which is still fee for service and maybe with shared saving on top and not global capitation yet, I would still agree that the elderly, frail elderly, duals, and particularly maybe even a focus on reducing readmission has the most oomph to a hospital-based health system right now because of that coupled disincentive on the Medicare value-based purchasing hospital readmission. So there is an immediate benefit to them to at least not be the worst. So if it addresses that and they're in a shared savings possibility, then you may be addressing the foot in both canoes. I think that the duals, though, is particularly hard just because of the whole complexity of payment. I mean, trying to get our Medicaid program interested in that when Medicare reaps the benefit, you know, you should immediately get into that. But so that's why I broadened it a little bit to the frail, elderly, disabled, you know, those at highest risk, and then a particular focus maybe on readmission. And there is some of that great work going on right now through the Community-Based Care Transitions Program, which isn't quite exactly community health worker, but could be, yeah, so.
Okay. Good. And actually, as you all know, as many know, there are going to be a lot of community health worker programs on which we will get more evidence soon, because we were actually contacted by Medicare, Medicaid. They want us to brief them because almost every single grantee that they have in the state innovation grants is using community health workers in some way. And they actually at CMS Central are trying to figure out, well, we've just sparked a whole lot of community health worker activity. We don't really know anything about that yet. What can we learn about how to structure our current program officer relationship with these efforts and future grant making so that we can achieve both the data that we want and also provide future infrastructure for healthcare delivery system innovation that we want. So we're at a very interesting time when it comes to decision making around CHWs. Let me suggest, with about 45 minutes left at most, that we should take a look at the best practice recommendations that were part of the draft report. I'd like to thank why don't you guys actually, why don't you get your copy, if that's where you're going. Yeah. You were trying to escape?